Chronic kidney disease today, and that's it. So it's 51 slides. Whenever we get through it, we're done. And then tomorrow we'll do exam review. And then you'll have the better part of a week to prepare before the exam. One housekeeping note on the exam. So I did make some additional modifications to the review slide deck yesterday, so I'm going to upload a new version of that today. So if you've already downloaded the review slides, I'll send something out on Canvas and let you know when it's been updated. I'll also change the name of the file so you know that it's different. But there will be a slightly modified review deck. I didn't take anything away from it, but I did add to it. Okay, so there are things. So if you looked at both slide decks and put them side by side and see what the differences are, it might give you some clues as to what might be on the exam. Okay? I will also tell you now, and I'll remind you tomorrow, everything that you need to get 100% on the exam is in the slides. There's nothing from any outside sources. If I said it, but it's not in a slide, it won't be on the exam. Okay? And I guarantee you that when you go through the exam after you've completed it and look at the answers and look at the explanations for the correct answers, you will find the slide that they came from in the explanation. Everything you need is in the slide decks. Okay? There won't be any gotchas, and there's no guess what I'm thinking type questions. It's very straightforward. Okay. All right. So, chronic kidney disease. Learning objectives. So, chronic kidney disease is an insidious process. The biggest risk factor, really, when you take the obvious underlying causes, medical conditions out of it, is just age. As we get older, our kidneys don't work as well as they did before. If you have somebody who lives to be, in their 90s or older, their kidneys definitely don't work as well as they did when they were in their 20s. But when you add on top of it other medical conditions, the most common culprits being diabetes and hypertension, at least in the United States, that can potentially increase the rate, the speed with which someone develops chronic kidney disease. And some of this is going to be tied back to the lectures that we've had before, like you see here, tubular interstitial disease, interstitial nephritis. We've talked about nephritic syndromes, so inflammation in the kidney. This is often caused by medication, as we mentioned before, and it can be acute or chronic. Having a history of suffering from these conditions previously definitely increases the person's risk of developing chronic kidney disease over time. So if you had somebody who developed acute tubular necrosis, maybe because they drank antifreeze. I know I keep coming back to that example. It's a popular board question. Or they had acute interstitial nephritis from PPIs, then in an acute setting, they can progress to end-stage renal disease. But over time, even if they recover from that initial insult, they can end up developing chronic kidney disease. They may not return to their original baseline function. Okay. So when you think about it, it makes sense. Right? You have some insult to the kidney, which increases the scarring to the glomeruli, which leads to progressive loss of nephrons. This is part of the reason why we're more aggressive about doing nephron-sparing surgery, particularly in the cases of like renal cell carcinoma, like we talked about yesterday. If it's possible to just remove the tumor and leave the rest of the kidney, we will. We get even more aggressive if you're talking about somebody who already just has a solitary kidney, either because they already lost one or maybe they were just born with one kidney. Anything we can do to preserve nephrons is very, very important. So lose nephrons, GFR drops, BUN and creatinine go up, proteinuria goes up. I don't know if you remember this from the hematuria proteinuria lecture, but albuminuria is an independent risk factor for all-cause increase in morbidity and mortality. So this is part of the reason why chronic kidney disease is a problem. I mean, it's a problem just on its own, but having spillage of albumin in the urine is an independent risk factor for all-cause morbidity and mortality. We've become a lot more aggressive about trying to manage chronic kidney disease, prevent people from getting to the point where they have chronic kidney disease. There's been a lot more guidelines published on management of kidney disease, even just in the time that I've been in medicine. The last major update to these particular guidelines for the International Nephrology Society was in 2012. But there are much better guidelines in existence now than there used to be. So what is chronic kidney disease? GFR less than 60 for greater than or equal to 3 months. Okay. If somebody meets these criteria, then by definition they have some stage of chronic kidney disease. We've talked about all of this before. Just think about all the things that we've talked about in every lecture leading up to this point and apply it in a prolonged situation. Right? Greater than 3 months, persistent. And I think we talked about this yesterday, but by definition, somebody who's had a renal transplant for some reason, even if their transplant is functioning normally and they have normal renal function from the perspective of their fluid electrolyte status, their acid-base status, all those things, they still, by definition, have chronic kidney disease, even though they have a fully functional transplant kidney. Here's your stages. I know it says 4 stages and then it lists 5. There are technically 4 stages, but some people break them out this way. Okay. There's not going to be a question on the exam where you're given a GFR and it says what stage of kidney failure is this person in. Just know that these are the stages. So if you're seeing a patient in clinic when you get out to your clinical rotations or after you graduated from the program and you're reviewing laboratory work, you can slap a stage on their kidney disease. Yes?
So stage 2 is just like mild decrease, but it does not qualify as chronic kidney disease?
Right, so they have some underlying kidney damage. Like if you know what their baseline was and they've decreased into this range and it persists for more than 3 months, then they fall in that stage. Yeah.
But it wouldn't be considered chronic kidney disease.
So if they have kidney damage present and they've had a decrease from their baseline and it's been persistent for more than 3 months. So cause, your GFR category, and the degree of albuminuria is how you classify their underlying chronic kidney disease. Again, this level of minutia is not going to be on. This is more just for your knowledge. Another way to think about it, if you like looking at charts, same thing. Every time I look at this, it makes me think of a risk assessment matrix. But if that's helpful for you to think about it in terms like this, then there you have it. Okay, so as I mentioned, diabetes, hypertension, And then all the different types of glomerulonephritis. So all of these things, like I said, anything that potentially causes an injury to the nephrons has the potential to cause somebody to progress to chronic kidney disease. It increases the risk of that happening over the course of their lifetime. Diabetic nephropathy. When you're talking about medical conditions, diabetic nephropathy is by far the most common cause of chronic kidney disease. And we've talked about this. So, chronic hyperglycemia damages the nephrons, decreases GFR, and if they're poorly controlled, if their A1C is chronically greater than 7, that drastically increases their risk of developing heavy albuminuria, which all cause mortality, morbidity increase, and is an early indicator. So urine protein creatinine ratio, as we talked about before, is an early indicator that somebody is going to progress to chronic kidney disease. Okay. Hypertensive nephropathy, second most common cause. Lots of high blood pressure in the United States. People are sedentary, they're obese, they don't have good diets, and if you don't manage somebody's blood pressure well, then over time, the progressive injury to the nephrons is additive. Okay.
Will they reverse it if the disease becomes under control?
So if there's already been damage to the nephrons are a finite resource. They don't come back, which is why we're so aggressive about, again, like things like nephron-sparing surgery, because once you've lost a nephron, you've lost it. Nephrons are like neurons. They don't come back, unfortunately. Now you can slow or stop the progression if you really get the underlying disease process under control. So I'll give you an example. Go back to the transplant patient. So one of the things that is often done for very brittle type 1 diabetics, have y'all heard that term before, very brittle, in describing people with diabetes? No. So brittle diabetic is someone who can be as aggressive as you want them to be with managing their diabetes, and they still just don't have great control of their blood sugar. They do everything you ask them to do, and it just, they have wild swings, they can't keep their blood sugars at an appropriate level. If you have someone who is a type 1 diabetic, so they're born with it, and they just can't control their blood sugars, they can end up in renal failure relatively early on in life because of their diabetic nephropathy. And what they'll often do for those patients is at the same time that they do a renal transplant, they'll also do a pancreas transplant. In case you didn't know that was a possibility, it is. I've actually done a couple of them in residency. And the goal there is to improve their glycemic control at the same time that you're giving them a new kidney. Because if you just put a new kidney in a brittle diabetic, what's going to happen to that transplanted kidney? They're going to knock it off, right? So anything that you can do to improve their outcomes from a blood sugar standpoint will be helpful. And so if they have any residual function in their native kidneys, and you're able to correct their diabetes, then whatever residual function they have will remain. So if you correct the underlying disease process, then whatever progression that was there halts, but they don't regain nephrons. Make sense? All right, glomerulonephritis we've talked about a lot. Anything that causes repeated glomerular inflammation, thickening of the basement membrane, which causes a decrease in GFR. Hopefully this is all review at this point, because it should be. So as nephrons are lost, the kidneys actually become overall atrophic. So if you look at a CT scan of a patient with chronic kidney disease, whether they've had a transplant or not, their native kidneys get smaller over time. They shrink. Now the residual nephrons, if you were to look at them microscopically off of a renal biopsy, the nephrons themselves actually hypertrophy compensatorily to try to pick up the load. But the nephrons that have been knocked off, they involute, they atrophy, and the kidneys will shrink. But by virtue of the remaining nephrons getting bigger and try to carry the load, it increases the burden placed on them, which potentially increases the rate at which they sclerose and scar. So the longer a person has chronic kidney disease, whether you control the underlying disease process or not, you're still putting an excess load on the remaining nephrons, which places them at risk. And as you can see, it's a vicious cycle. One begets the other. Questions on that? Okay. Early stage CKD is asymptomatic. Chances are you'll see a patient out there, probably still on active duty, probably not very old, and they just come in for their annual well check, and you look at their labs, and hey, this person's GFR is less than 60. And they won't have any idea that they've had a decline in their renal function, because there's no outward signs. Now, obviously, if they have one of the other acute conditions that we've talked about before, if one of those things happened, then they're going to have known that one of those things has happened. You know, like IgA nephropathy or post-infectious glomerulonephritis. But if they just had poorly controlled blood pressure and didn't know, if the only encounter they've had with a healthcare provider for several years has just been a PHA, which the majority of them are done by telephone now, not checking somebody's blood pressure over the telephone, then they may have developed the early stages of chronic kidney disease and not realize it. We've talked about uremic syndrome before. Any questions about any of this? All right, so talking about uremic syndrome, we've talked about this before, but this is your presenting symptoms. Some of them, well, a lot of them are non-specific. How many different things cause restless legs? Lots of stuff. Idiopathic, medication, uremic syndrome, fatigue, nausea, instability, insomnia. If you've got somebody who's presenting with these type of symptoms and you don't have a good reason for it, pay attention to what their metabolic panel looks like. Look at their GFR. Look at their BUN and creatinine. Uremic fetor. Anybody ever noticed that elderly people often have sort of a foul smell to their breath, no matter how clean their teeth are? They could have just brushed their teeth and used mouthwash. And if you've ever talked to an elderly person up close, because they don't hear very well, you got to get close to them. You can smell their breath, and it just doesn't smell right. That's uremic fetor. And they may not have any underlying medical condition. They're just old, and as a result, their GFR has dropped, and they have bad breath as a result of it. Think of it in terms of like that old person smell. And then chronic kidney disease begets hypertension. So that's the most common complication of chronic kidney disease. So as the nephrons sclerose, throughput of oxygenated blood goes down the arterioles, and then the vessels in the glomeruli are more sclerotic, and as a result, it triggers the angiotensin, or the renin-angiotensin system, which increases the level of hypertension that they have, which makes the problem worse, which increases their hypertension, which makes the problem worse. Cardiovascular disease is really what kills these patients before they get to end-stage renal disease. They don't die because they need to be on dialysis. They die because they develop atherosclerotic plaques, have a heart attack, a stroke, an aortic aneurysm, and ruptures. If you find kidney disease, look for heart disease. If you find heart disease, look for kidney disease. Chances are if they've got one, they've got the other. And if you're not managing both, you're really kind of behind the power curve. This is part of the reason, I don't know if you guys have heard this yet, but nephrologists and cardiologists fight about blood pressure a lot. If both nephrology and cardiology are consulted on the same patient, they'll argue about how to manage them. They'll argue about whether or not it's the kidney's fault or the heart's fault. Who here has watched any of the videos by Dr. Glaucom Flecken? Yeah, so he talks about this. He's got videos where there's arguments between nephrology and cardiology. And you can probably go on YouTube and search Glaucom Flecken nephrology cardiology and just go straight to some of the videos that he has about those two specialties arguing with each other. Right, so congestive heart failure, if they have uncontrolled hypertension or progressively worsening hypertension, regardless of whether it was the heart's fault first or the kidney's fault first, they can progress to congestive heart failure, right? And this is a lot of this should be relatively self-explanatory. I mean, you know that high blood pressure increases workload on the heart. You know that increased workload can lead to CHF. And your modifiable risk factors, the things that you need to be thinking about, are managing their high blood pressure. If they're a tobacco user, get them to quit. Manage their lipids. Treat all of those things aggressively in patients with chronic kidney disease. Keep them from progressing. If they're already at CKD stage 1, you want to keep them from progressing to stage 2, stage 3, etc. We've talked about cardiorenal syndrome. Do I need to beat this dead horse? So, kidney bad, hurts heart, heart bad, hurts kidney. Over and over and over again, everything just keeps getting worse until eventual death. We've talked about derangement in fluid and electrolyte balance, and I know I mentioned briefly issues with mineral metabolism, specifically talking about osteomalacia. So if you have somebody who, for example, as a result of their chronic kidney disease becomes acidotic, they have a metabolic acidosis, what does that do to the mineralization of their skeleton? Does it get stronger, stay the same, or get weaker? It gets weaker, right? Both because the acid levels are potentially literally eating away at their skeleton, but also because the body's trying to compensate and increase the amount of bicarb, increase the amount of buffer in the bloodstream, and so they end up with osteomalacia. Also, you end up with issues in vitamin D metabolism in patients with chronic kidney disease. So all of those things can result in disorders of mineralization. So you can see here this osteodystrophy in this X-ray. See these lytic lesions in the phalanges. Now, this is secondary hyperparathyroidism as a result of chronic kidney disease, but there's lots of things that can cause lytic lesions myeloma is one of them. So just seeing an x-ray like this, the first thing you think shouldn't necessarily be secondary hyperparathyroidism secondary to chronic kidney disease. But if you have somebody who has chronic kidney disease and they've got skeletal issues, it's probably an underlying contributing factor at least. Phosphorus restriction, phosphorus binders for patients that develop hyperphosphatemia. I have never seen these drugs prescribed by anyone other than a nephrologist, ever. That doesn't mean you won't ever do it, but like it says on the slide, these should be managed by an experienced clinician. And check a vitamin D level, because that's easy to fix. If somebody's got a vitamin D deficiency, whether it's because they're not taking in enough vitamin D, they're not getting enough sunlight, or it's a derangement in metabolism because they've got chronic kidney disease, give them vitamin D. Anemia, coagulopathy. So coagulopathy can develop because of derangement in acid-base status. It may develop because the platelets are not being manufactured correctly because they're not getting the correct stimuli in the bone marrow. It may be because the patient has other deficiencies in their diet. Their thyroid may not be working well. They're a chronic alcoholic. They may not be getting enough vitamin B12 or folate. So be thinking about all these things. These are relatively routine labs that you should be checking on patients with chronic kidney disease. Questions about this? Okay. So as kidney function degrades and the patient is not able to maintain their acid-base and fluid and electrolyte balance, they can develop hyperkalemia. Self-explanatory, right? We've talked about this a bunch already in previous lectures. If the only thing they've got going on is chronic kidney disease, so they don't have some acute process going on, generally the kidneys maintain their ability to maintain homeostasis of potassium until they get fairly far along in chronic kidney disease. Like it says, potassium balance usually remains intact until the GFR is less than 10 to 20. But it can happen earlier than that. So if you're managing a patient with chronic kidney disease, don't just look at the BUN and creatinine, look at their electrolytes too. As we know, hyperkalemia can be a bad problem. If you get a potassium level higher than 5, and then you start worrying about, do they have EKG changes? And then, like we talked about in the acid-base disorder lecture, if they can't process hydrogen ions, if they can't manufacture ammonium, then they're going to become acidotic. We've talked about uremic encephalopathy before. Again, all those sort of non-specific neurologic manifestations that can occur with decreases in renal function. If you have somebody who's not mentating well and they have chronic kidney disease, look at their BUN and creatinine, see if that might be the underlying cause. And we talked about creatinine doesn't cross the osmotic barrier in dialysis, right? It's too large of a molecule. But you can improve their acid-base balance with dialysis. So you can improve their blood urea nitrogen. So you can have improvement of these neurologic symptoms that are caused by uremic syndrome that is causing uremic encephalopathy but you're not going to see a change in their creatinine if they're on dialysis. If they've already developed peripheral neuropathies, that's not going to get better. I mean, think about it. If somebody develops peripheral neuropathy as a result of poorly controlled diabetes, when you get their blood sugar under control, can they suddenly magically feel their feet again? Does their fine 2-point discrimination get better? No. So that's not going to improve with dialysis, but if they're not mentating well, that might improve. Should improve, actually. Now, the patient may not appear ill at all. Like we said at the beginning of this, if it's early stage chronic kidney disease, they may be completely asymptomatic. But if they've got stage 3, stage 4 chronic kidney disease, then they may look pretty ill. And then if they're developing these secondary problems, hyperkalemia, metabolic acidosis, then they're not going to pass the eyeball test. They're going to look at them and go, well, this person's sick. I may not know why they're sick, but they look sick. And then look at the metabolic panel and you'll probably figure it out. So we talked about, or at least I mentioned, uremic frost earlier on this week. That's what you're seeing in this upper right-hand picture. So I know it might just at first glance look like, maybe she's just got dry skin. Looks kind of ashy around the jawline. That's actually uremic frost. Deposition of uremic metabolic byproducts is actually coming out with sweat. And then it crystallizes on the skin. They may have peripheral edema, they might not. If they're volume down, then they're probably more likely going to have dry skin. Their turgor's going to be off. They're going to have tenting, that sort of thing. But if they're hypervolemic, then you're definitely going to see peripheral edema. Maybe not necessarily like anasarca or periorbital edema like you might see in minimal change disease, but that pretibial edema, scrotal edema, likely to see that. So just sort of a general summary of how to approach chronic kidney disease from a primary care standpoint. Everything starts with a physical exam. I cannot stress how much you can gain from actually examining a patient, putting hands on them, looking at them closely, not just sitting on the other side of the room and talking to them. History of nephrotoxic medications, their medical history. Have they had issues with their kidneys before? Have they had conditions that contribute to renal dysfunction? Other urinary tract abnormalities, their social and environmental history, family history, polycystic kidney disease, it's genetic, right? And then your laboratory tests. But these are all the things you should be thinking about when you're seeing a patient in clinic. Whether they have chronic kidney disease already and you know it, or you're screening for it. So their urinalysis will probably be abnormal. It won't necessarily be abnormal, but it might be. Almost certainly will be if they're significantly progressed. If they've got stage 3, stage 4 CKD, their urinalysis is going to be abnormal. They also may be olivuric, so you may have a hard time getting urine from these patients. Waxy casts, hyaline casts. I can't remember if we talked as much about hyaline casts. Hyaline casts are casts that they have a shape, you can see them, but they don't have any cellular material in them. So there's no renal tubular epithelial cells, there's no red blood cells, there's no white blood cells. It's a protein cast. They're also sometimes described as bland cast. So we talk about a bland urinalysis, bland urine. Don't confuse bland urine with bland cast. You won't see that term as much anymore because it is kind of confusing. But a hyaline cast is just a cast that's visible on microscopy that doesn't have any cellular material in it. And then we've talked about all the serum findings before. Any questions on this? So, following their renal function panel over time, because remember, to meet the definition of chronic kidney disease, it has to be persistent for more than 3 months, right? So make sure that you're not just looking at the patient's most recent labs. Make sure you go back and look at the history. Look at what their trend has been over time. Obviously, if somebody has an acute condition that causes a decrease in the renal function, they might recover from that. So the key is, how long has this decrease in function been persistent? Again, sort of a diagrammatic approach to it. Hopefully this is all review from the previous lectures. You will not see this diagram on the exam. Okay. Albumin-creatinine ratio. I've already mentioned this once today. It's important. It's not just a oh, I do this because it's part of the screening process. If they've got albuminuria, then they're at increased risk of cardiovascular disease, all-cause morbidity, mortality. So make sure you're looking at that. Renal ultrasound in chronic kidney disease. You may see things that are grossly abnormal, you may not. The most common thing you're going to see, as I mentioned before, is atrophic kidneys. So their kidneys are going to be smaller than they should be. Now, if you have an ultrasound from earlier in their life that you can compare it to, that may be even more obvious. But if their kidneys are less than 9 to 10 centimeters in distance from pole to pole, technically those kidneys are smaller than they should be. And scarred renal tissue is more echogenic than normal renal tissue. So another good surrogate, a way to look at it, is that if they have a normal liver and they have normal kidneys, then the appearance of the liver compared to the appearance of the renal tissue on ultrasound should be about the same. If you're looking at their right kidney on ultrasound and you can see part of the liver in the same image, and the liver looks nice and dark and the kidney looks brighter white, then that's an indication that there's been some sort of scarring that's occurred in their kidney over time. And I mean, you can make that determination without lab work. I mean, obviously you need lab work and history to really understand what's going on with the patient. But if the kidney's small and the kidney's more echogenic compared to the liver, then there's probably parenchymal scarring in place. If they've got something like polycystic kidney disease, the kidney's probably not going to be atrophic. It's going to be huge, right? Remember the picture from yesterday? Two kidney specimens that have been removed and they're the size of footballs or bigger. So it's not necessarily going to be an atrophic kidney. if they've got some of these other underlying conditions that are causing their chronic kidney disease. But if they're just old and their kidneys are worn out, then they're going to shrink. ACE inhibitors or ARBs are the initial drug of choice, just like they have been for everything else that we've talked about this week. Tight glycemic control in diabetics, low phosphate diet, let the nephrologist manage their phosphate binders if they need them. Cautious with diuretics. Is giving a diuretic to somebody who already can't make urine, is that potentially going to help them? Probably not. You will see patients with chronic kidney disease that are on diuretics, and they may benefit from being on a diuretic, especially if they have issues with maintaining their potassium levels, and putting on a loop diuretic can help with managing that. But if their renal function is already really, really poor, if they're not making urine, then putting them on a loop diuretic is probably not going to help. Then that's when you start thinking about things like potassium binders, like Kxalate. Something that actually binds potassium in the diet and keeps it from being absorbed. So it just comes out in the gut. And then DDAVP. Have you heard before that DDAVP can help with bleeding problems? It improves platelet function if they're uremic. Talked about all this before. Vaccinations are important. If you're concerned about preventing infection where you can, you should. So making sure they get their flu shot annually is very important. Make sure they get their annual pneumococcal vaccination. And if they have underlying chronic kidney disease already, the likelihood that they're going to have an AKI goes up. So I'll give you a personal example. So my grandfather, who was an Army chaplain for 29 years, what ultimately killed him was he had chronic kidney disease at baseline because he was in his 90s, and he got pneumonia. And as a result of the pneumonia, he got an acute kidney injury on top of his chronic kidney disease. So he was hypotensive for a while, and it ended up pushing his renal function beyond the point where he really needed dialysis. And he actually made a conscious decision that he didn't want to go on dialysis. My grandmother had died a couple years previously. He had issues with chronic back pain. He was just worn out. He said, no, I don't want to do that. He went on hospice, and about a week later he died. So it can be a very, very quick end if somebody ends up in a position where they need dialysis and they don't get it. One of my instructors in residency, our program director actually, used to say, uremia is not a bad way to go. So if somebody is in renal failure and they decide that they don't want to have it treated, if they once they become uremic enough, they just become obtunded, slip into a coma, and I guess in the grand scheme of things, die relatively peacefully, but also very quickly. So just know that your patients with chronic kidney disease are at increased risk. Another one of my colleagues used to say, this person can't take a joke. So if they have poor functional reserve, if they're already at a significantly decreased level of baseline function and something happens to them to push them further, the resulting complications can be outsized compared to someone who has normal functional reserve. So if they can't take a joke, the implication being that if you just made them laugh too hard, that they would die. It's a way to think about it, right? So if they already have poor functional reserve, very, very minor changes in homeostasis can have outsized effects. So we talked about SGL2 inhibitors a little bit earlier on. If you remember the slide that had the New Kids on the Block poster on it. Relatively new in the grand scheme of things, but certainly something that is being used more often now for treatment of chronic kidney disease. And it is becoming the standard of care. They didn't exist when I went through medical school or residency. This is very, very new. You may find yourself in a position where you're starting patients on SGLT2s in primary care. Because of the risk of cardiovascular disease, one begetting the other, as I already mentioned, you need to manage their cardiovascular risk as well. Anything you can do to minimize their cardiovascular disease is helpful. There are lots of 10-year cardiovascular risk calculators online. If you haven't seen those before, you just Google 10-year cardiovascular risk calculator, and you'll probably get 5, 6, 7 results. They're all different. Some of them are more detailed than others. Have many more data points that they want you to enter to calculate a person's 10-year risk. Obviously, the more information you put in, the better the information you're going to get back. But you may not have access to all the things those risk calculators are asking for, so do what you can with what you have available. If they've got hyperlipidemia, treat it. If they need to be on an antiplatelet agent of some sort, even if that's just baby aspirin. And I'm sure it goes without saying, don't just start them on medication and say, okay, well, we put you on a statin, you're fine. Follow up on that, see what effect it had on their lipid levels, and make modifications as necessary. So, cautionary medications. Everybody, we keep saying everybody needs to be on an ACE inhibitor, but it's also something you need to take caution with. Why?
NSAIDs.
So talking specifically about ACE inhibitors. So remember we talked about with renovascular hypertension? You can, if you start somebody on an ACE inhibitor, they can actually end up having worsening of the renal function. So be mindful of that, knowing that ACE inhibitors are beneficial in patients with renal disease and hypertension. It reduces proteinuria, but if you're starting somebody on an ACE inhibitor for the first time, it's probably a good idea to see them back in a relatively short interval, like a couple of weeks, and recheck their BUN and creatinine, and make sure that you didn't inadvertently do something bad. Obviously, NSAIDs are nephrotoxic. Antimicrobials can cause interstitial nephritis. Penicillin is a classic one. So something you might see on the exam as sort of like a confounding question is the stem of the question might have you thinking about post-infectious glomerulonephritis. Patient had strep, was treated with penicillin. If you see something like that, be thinking interstitial nephritis, because they might be trying to fool you. Obviously, aminoglycosides are nephrotoxic. Any questions about any of this? We've talked about intravenous contrast a lot too, right? So anybody who, if you think you need to get imaging on somebody and you're thinking about a CT scan with contrast, always look at their creatinine first. Sometimes it's unavoidable. If you, common example, if you have somebody who you're seeing in the emergency department and they've got stroke-like symptoms, is there any substitute for getting a CTA on that patient? So if they've got poor renal function and you would otherwise balk at giving them a contrast load, in that situation, your hands are tied. I mean, you should still have a conversation with the patient and say, hey, you may be having a stroke. The only way for us to determine whether or not you're having a stroke is to do this imaging study. We need to give you contrast. It's potentially going to be harmful to your kidneys. If you're having a stroke, that's going to kill you a whole lot faster than a degradation in your renal function. How do you want to proceed? But I mean, you will find yourself in situations where you don't have good options, and you have to pick the lesser of the two evils. Refer these patients to nephrology early. The sooner you get a nephrologist involved in managing them, the better their outcomes are going to be. I mean, that's what these people train for years and years and years, right? Is to manage renal dysfunction of all varieties, and they're in a better position to take care of the really complicated situations that arise in chronic kidney disease. Also, you need a nephrologist on board for a person to go on dialysis. So if they're progressing towards end-stage renal disease that might be dialysis dependent, or if you think they're going to be needing a renal transplant, the earlier you get them engaged with nephrology, the easier it is to get those things in place. We're on slide 4451. You want to press on or take a break?
Push.
Okay. So, hemodialysis, peritoneal dialysis. Have you guys learned about peritoneal dialysis? Yesterday. Great. So, advantages of peritoneal dialysis are it can be done at home. Typically is done at home. They hook themselves up to their peritoneal dialysis machine at night and let it run through the night while they're asleep. Prevents them from having to go in for hemodialysis at a dialysis center. Obviously, the definitive management is a kidney transplant, provided that they're a candidate for it. Healthy enough to tolerate the transplant. So they need to be capable of surviving transplant surgery, but they also need to be a patient who is going to benefit from having a transplant, meaning they're going to take care of it. And that doesn't mean that patients who have had failed transplants in the past shouldn't be considered for additional transplants. I know I mentioned this to somebody. There's a guy that I went to college with who had IgA nephropathy, and he had 5 kidney transplants. It wasn't his fault. He kept knocking off his kidneys. He was doing everything that he was expected to do, managing his diet, taking his medications, all the other things. He had a defect in IgA creation, right? His IgA wasn't glycosylated correctly. He had IgA nephropathy. And even when you put in a new kidney, that doesn't mean that kidney is immune to the underlying disease process. If you have somebody who's a poorly controlled diabetic, and it's not because they're brittle, it's because they just don't do what they're supposed to do, then they're not necessarily going to be a great candidate for a transplant. Especially if they've been given a transplant and they didn't take care of it, then a transplant surgeon is going to be a whole lot less likely to be inclined to give them a repeat transplant. Now, I know I told you before, transplanted kidneys go in the pelvis. So what happens if somebody's had a transplant, they've had one, and their transplant fails and they need another transplant, where does it go? The other side of the pelvis. So they're put off to one side because you have to connect the vasculature to the iliacs. So it's going to go on one side. So now you've got room for another one on this side. What if they need a third one?
Remove the first one?
You can connect it to the aorta and the vena cava just above the branch if you've got enough length on the ureter. Occasionally, you'll end up in a situation where the transplanted kidneys have to be removed in order to make room for a new transplant. But if there's real estate that can be used, they'll do that before they talk about taking anything out, because removing a transplanted kidney is just an added insult, increased risk and morbidity and mortality associated with surgery. So whatever they can do to not have to take an old kidney out when they're putting a new one in, they'll do. But eventually you run out of real estate. So hemodialysis we've talked about a lot. Yes?
Sorry, I was just curious. So does the atrophied kidneys, do they ever like become do they ever necrose in nature to where they would need to be removed?
So no, typically not. They can get infected though.
Okay.
So we'll talk about this more in the urology section, but you can get pyelonephritis from either an ascending infection that starts in the bladder and goes up the ureters, but you can also get pyelonephritis from a hematologic source. So if they're sick from something else and they've got atrophic kidneys, they're at increased risk of hematologic spread of whatever bacteria was circulating in their bloodstream, having it actually take hold in the kidneys, and that might be an indication to remove an atrophic kidney. Significantly atrophic kidneys can be hard to find in the operating room. Like they can be difficult to locate and actually take out because they've shrunk so much. But if they are chronically infected, then that can be a reason to take them out. But do they just become necrotic on their own? No, they just involute and scar. So dialysis. So if somebody needs dialysis acutely, they have to have a large dialysis catheter placed, which is usually placed either in the groin or in the subclavian. And you can't leave those in permanently. Right? Increased risk of infection from an indwelling body, indwelling foreign body. So in order for them to go on chronic dialysis, they have to either have a graft put in to create a fistula between the artery and the vein, or they'll surgically anastomose two vessels together to make a fistula, an intentional fistula. And then that's what they end up using for somebody who's on chronic dialysis. They're able to put a very, very, very large bore needle directly into that fistula, and that allows for much more rapid transition of the blood. That's why somebody who's on chronic dialysis, the dialysis session might only last for 4 hours, because they can do that much blood exchange through that large of a cannula. Your temporary dialysis catheters are like 14 French, which is pretty big. So your basic Foley catheter that you'll find in a normal run-of-the-mill adult catheterization kit for draining the bladder is going to be between 14 and 16 French. So think about it in those terms. You're putting a tube that big into somebody's vasculature to allow for the blood exchange to take place as rapidly as it needs to. So obviously you can't do that through a regular needle. So the needles that they use for dialysis are huge once a patient has a mature fistula. Also, fistulas have to mature. So you can't just have a vascular surgeon build somebody a fistula and then use it the next day. The fistula has to usually 4 to 6 weeks to heal before they can start using it for dialysis. Right, peritoneal dialysis, this is what a peritoneal dialysis machine looks like. They don't all look like this. Obviously, there's different brands out there. But the dialysate, rather than being separate and on the other side of an osmotic filter in hemodialysis, the dialysate's actually infused into the patient's peritoneal cavity through an implanted catheter. Like it's like a G tube. So, G tubes can be placed and left, be left there indefinitely. I mean, they have to be changed periodically, but they don't have to be changed out nearly as often as a vascular catheter. And then they infuse the dialysate into the peritoneal cavity, and then that causes an osmotic gradient across the gut. So the mucosal surface of the intestines is just as capable of exchanging metabolic products as the inner lining. The inner lining is more efficient because of the villi, more surface area, but that's what allows peritoneal dialysis to work. So you put dialysate in the abdominal cavity, and that change in osmotic pressure allows the toxins, if you will, the waste products that you're trying to get rid of, diffuses across the wall of the intestine externally into the dialysate, and then it gets pumped out back through the peritoneal dialysis machine. So here's a peritoneal dialysis catheter. And patients do this themselves. I mean, as long as they've got the dexterity and the mentation to be able to do it on their own. They might have a family member that has to do it, or home health. But otherwise, they do it themselves. They hook it up, turn it on, get up the next morning if they're doing it overnight, and disconnect it. Okay, we've talked about transplants a lot. A couple of other details that we haven't talked about. Transplant list is big. And this we're just talking about kidney transplants here. So imagine how much larger this number is when you talk about everybody who needs a transplant for some reason. Lungs, heart. There's a lot of people on the waiting list. I always encourage people to be organ donors, because if you're dead, you don't need it anymore, and somebody else might benefit from it. If you have somebody who's otherwise healthy and doesn't have significant whole body trauma from whatever caused them to die, I mean, you could potentially benefit 18 people from one donor for different reasons. Obviously, you're not getting 18 kidneys from one person, but you can get a kidney for one person, a kidney for another person, a liver for somebody, corneas, vessels, gut for people who have short gut syndrome. You can get a lot of benefit from one organ donor. I have done one deceased donor harvest. There was only one that occurred during my transplant rotation and residency. It was an 18-year-old female who threw herself from a moving car after an argument with a family member, hit her head, and was brain dead. And then the family decided that they would donate her organs. While organ donation is extremely beneficial, that experience told me that I could never be a transplant surgeon, at least not one that does organ harvest. I just didn't like it. I mean, they take everything they can take. Hearts and lungs go first because they're more sensitive to loss of blood supply, and they start taking the other organs that are able to be salvaged. Outcomes are really good for patients that take care of their kidneys after they've been transplanted, and living donors. The ability to take a kidney from a living donor is a game changer. It's huge. Methodist Specialty and Transplant Hospital here in San Antonio, at least at one time, I don't know if they still do or not, held the Guinness Book of World Records record for chain transplants, meaning they had, I'll go off on a little bit of a tangent here, but this is important for you to know just to put this in perspective. So let's say you need a transplant, and you want to donate a kidney, but you're not a match. Your kidney's no good for him. But you're willing to give a kidney to someone else if they have a donor who's willing to donate to them, who's a match for the person that you want to donate to. They did 19 of those in sequence, back to back to back to back to back, over about a 48-hour period, non-stop. They had multiple transplant teams rotating in and out of the operating room. They had one operating room where they were taking the donor kidney. In the next operating room, they have the recipient who's already in the operating room being prepped. They take the kidney out, they come over here, they start putting it in, they sew this person up, they take him to recovery, they reset this operating room, get ready for the next one. Over and over and over again, 19 continuous transplants in about a 48-hour period. Part of what allows them to do that is we've learned with kidney transplants that all of the genetic markers that they used to check for to see if somebody was a genetic match, they were actually being overly aggressive. They don't have to screen as aggressively for genetic matches as they used to. I'm not going to get into the nitty-gritty on that. Just know that they used to say you have to have X number of genetic matches across the spectrum of genes that they're checking for. And now they've determined that you don't actually need to have that many. It's a much smaller number, so it's easier to find a match that way. Yeah, okay, so prognosis, last slide. End-stage renal disease, 5-year survival rate, 40%. Average life expectancy is 3 to 5 years. That's for somebody who's on dialysis. If you're able to get them a transplant, those numbers improve drastically. But even on dialysis, people can live for a long time. And dialysis is expensive. I mentioned this before. It's the single greatest healthcare expenditure in the United States is people on dialysis for kidney failure. Because they can live a long time, and everything that's associated with it, both treating their underlying kidney disease and all their other dysfunctions and their other medical problems, doing the dialysis, doing the fistula implantation, all that stuff, and then you keep them alive, and it's just money, 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 money. So if we can solve this problem, end-stage renal disease, if we keep people from getting there, it takes a huge burden off of the healthcare system and healthcare budget. Questions? All right. So tomorrow we'll do the exam review. Like I said, I've got some updated slides. I'll get those uploaded this morning and send a note out on Canvas to let you know that they're there. The first half of the slide deck, if you haven't looked at it yet, is actual slides pulled from other lectures that are going to be high yield for you, and then the second half of it is example questions. None of the example questions are verbatim on the test, so it's not going to help you in that way to do the example questions. But they are representative of what the questions will look like and the topics will be like on the exam. Okay? But if you think you're gonna find a gimme that's a match, like if I just memorize these, I'm gonna find them on the exam, you won't. But the first half, the slides that are pulled from the other lectures are high yield. Like I said, it's the 80% solution. If all you do is study the review slide deck, you're going to get an 80 on the test. If you want to get better than that, you got to look at everything else. But everything on the exam comes from the slide deck, all of it. So, questions? All right, y'all. Have a good one.